You're looking to really grasp some complex stuff without getting totally bogged down.
Yeah, you want the key takeaways clear and efficient.
Exactly. And that's what we do here on the deep dive. We take something dense, like today, it's this pretty detailed medical chapter,
Right.
and pull out the core knowledge you really need.
And today, we're diving deep into how medical teams handle the initial assessment and treatment of severe physical injuries, multiple injuries often.
Our guide is this medical text, laying out the critical first steps.
Yep. And when we say trauma, we mean serious harm.
Could be blunt force trauma, car crashes, falls,
Hmm.
or less often, assaults.
Or penetrating trauma, stabbings, gunshots.
And the text mentions something interesting. Blunt trauma is maybe more common overall in Western countries.
Mm-hmm.
But penetrating trauma, you see that more in like big U.S. cities, South Africa, and obviously war zones.
And a key point is that blunt injuries can be sneaky internal, multiple sites, not always obvious right away. Penetrating wounds, well, they vary hugely. Depends on the path they take, the force involved.
The main thing is
Yeah.
you need a system, right? A process.
Absolutely. A systematic approach and constant reevaluation. That's vital. So nothing critical gets missed in the heat of the moment.
Okay, so that's our mission today. Understand that systematic approach doctors use in these high-stakes situations.
Focusing on those initial priorities, the first assessments, what has to happen right at the start.
Got it.
So first up, triage.
Triage. Sorting people out.
Exactly. Like in an ER or on a battlefield.
Mm-hmm.
Who's got the most life-threatening injuries? Who needs help right now versus who can maybe wait a moment?
Makes sense. Prioritizing resources.
And the text stresses if the local hospital isn't equipped for really severe stuff,
Yeah.
getting that patient transferred to a proper trauma center is a really big consideration early on.
Right. You need the specialists, the right gear.
Huh?
And the text also says the overall severity depends on like how many injuries there are and how bad each one is.
Precisely. It's often a combination, not just one single thing.
And time is just critical.
Absolutely. So assessment, diagnosis, treatment, they often happen almost simultaneously.
Wow.
There's usually no time for long history or waiting for loads of tests before starting emergency care. You act fast on what you see.
So what are those immediate red flags? What screams critical injury?
Okay, the text points out a few key things. First, signs of shock.
Shock. Okay.
Now, there are different types, but in trauma, it's usually hypovolemic shock.
Hypovolemic, meaning not enough blood volume.
Exactly. Usually from major blood loss. The body just isn't getting enough blood flow.
Okay. Blood loss causing poor circulation. Makes sense. What else?
Second, a depressed level of consciousness. Sort of, not fully alert.
Right.
And that can happen for a few reasons in trauma. A direct brain injury, maybe not enough oxygen getting to the brain, that's hypoxemia.
Okay.
Shock itself can cause it. Or, alcohol or drugs might be involved.
Or maybe something else entirely, like a medical problem that caused the accident.
Could be. Like a stroke or a heart issue. But the interesting thing is, initially, they treat the level of consciousness, not necessarily the exact cause right that second.
So treat the symptom first, the reduced awareness, then figure out the why later.
In those first critical moments, yes, stabilize first. The third big sign is difficulty breathing.
Breathing trouble. Okay.
Very common with injuries to the head, face, neck, chest. If someone's breathing really fast or looks like they're struggling,
Yeah.
could be a blocked airway, maybe an injury to the larynx, the voice box.
Yeah.
Or they might have inhaled something, like vomit. That's aspiration,
Or damage to the lungs themselves.
right? Or the chest wall. Things like a collapsed lung, a pneumothorax, or a bruised lung, which is a lung contusion.
Okay, so those three shock, low consciousness, breathing issues, they paint a pretty serious picture.
Definitely.
Once those are spotted, what are the absolute top priorities? What comes first?
The text is clear. Priority 1 is supporting life. Resuscitation. Keep the patient alive while you figure everything else out.
Okay, keep them alive. Makes sense. Priority 2.
Find and stop any bleeding. Obvious bleeding from wounds, or, crucially, internal bleeding you can't see.
Stop the bleed. Stop the shock from getting worse. Got it. What's next?
Third, prevent more damage to the brainstem or spinal cord.
Critical.
These injuries are devastating, so protecting the nervous system from the get-go is huge.
No?
Then number 4 is diagnosing and treating all the other injuries and any complications that pop up.
So it's a cascade.
Mm.
Most life-threatening first, then work down the list. You mentioned that systematic approach earlier. How does that actually work in a chaotic ER?
It's absolutely vital. The text mentions established programs, like from the American College of Surgeons. These give a structure, a logical flow, so critical steps aren't missed.
And I think I saw something about ABC versus CABC. What's the difference there?
Ah, yes, that's really important. The classic approach is ABC. Airway, breathing, circulation. Check the airway, then breathing, then circulation. Simple. But based on battlefield experience mainly, the CABC approach is often standard now in trauma.
The extra C.
Stands for catastrophic hemorrhage. Massive, life-threatening external bleeding.
Ah.
The idea is if someone's bleeding out massively, you have minutes, maybe seconds, stopping that bleeding has to be priority one, instantly.
So if you see massive bleeding, you tackle that before even checking the airway.
Exactly. The text says stop it fast. Direct pressure, field dressings, maybe a tourniquet above the wound, special hemostatic agents,
Oh.
whatever works, quickly.
Wow.
Once that's under control, or if there wasn't any catastrophic bleeding to begin with, then you go to the standard ABC.
Okay, that makes a lot of sense. So let's break down CABC. We did C. What about A, airway? How do you spot an airway problem?
Okay, signs can be noisy breathing, gurgling, stridor, or paradoxically, no sound at all if it's totally blocked.
Right.
You might see weird chest movements, chest and belly moving opposite ways, obvious distress using neck muscles to breathe.
And if they're less conscious?
A weak or absent gag reflex is a worry. It means they can't protect their airway.
Ah.
And critically, whenever you manage the airway in trauma, you always protect the neck. Assume a cervical spine injury.
Got it. Protect the neck, ensure the airway. Then B, breathing. How do they assess that?
Breathing difficulty. Look for really fast breathing tachypnoea. Or maybe shallow, irregular breathing, cyanosis, that bluish tinge around the lips, fingertips, lack of oxygen.
Okay.
Even confusion can be a sign the brain isn't getting enough oxygen.
And C is circulation looking for shock. What are the signs there?
Right, circulatory shock, often hypovolemic from blood loss and trauma. Signs are like cold, clammy skin, delayed capillary refill.
That's pressing the nail bed.
Yeah, see how fast the pink color comes back? More than a couple of seconds suggests poor flow to the limbs. Also, a rapid weak pulse and low blood pressure.
But you said low blood pressure can be late.
Exactly. That's a key point the text makes. Tachycardia, a fast heart rate, isn't always there either. So low BP can be a late sign. They might have lost a lot of blood already.
Crucial point. Can't just rely on one thing. Okay, we're up to D and CABCDE. What's D?
D is for disability. Quick neurological check.
How's that done?
Check the pupil size, reaction to light, and use the Glasgow Coma Scale, the GCS.
Right, the GCS score.
It scores eye-opening verbal response, motor response, gives a standard measure of consciousness. And remember, low consciousness could be shock, direct brain injury, or substances like alcohol or drugs.
Okay, and finally, B.
E is for exposure. You need to fully undress the patient to examine them properly, see everything.
Makes sense.
But, and this is vital, you must prevent hypothermia to come warm and maintain dignity. Expose only what you need to examine at that moment. Use warm blankets.
Okay, so CABCDE gives that rapid systematic check for immediate threats. After that, what are the next immediate treatments and tests?
Several things kick in quickly, often at the same time. High flow oxygen for almost everyone.
Oxygen first.
Yep. And since breathing is often affected, many need help breathing ventilation support, maybe a machine.
What if they're agitated?
If they're restless, uncooperative, making things difficult, they might need rapid sequence induction meds to sedate them quickly so a breathing tube can be placed safely.
Ah, okay. Secures the airway fast. What about blood tests? Transfusions?
Well, it gets drawn right away for baseline tests,
Mm-hmm.
blood counts, kidney function, liver function, that sort of thing. Blood alcohol level too, which the text notes can be useful clinically, not just legally.
Right.
And blood is sent urgently for cross-matching. Usually start with asking for maybe 6 units of red cells because you just don't know how much they'll need. Most places have protocols for getting blood products in fast if someone's bleeding badly.
And fluids. They must need fluids fast, especially with blood loss shock.
Oh, absolutely. IV fluid resuscitation is key. First choice is usually isotonic crystalloids, normal saline, or similar balanced salt solutions.
Okay.
But if they're clearly in shock from bleeding, getting blood products in early is crucial, like we said.
How do they get fluids in fast enough?
Big 4 lines, large gauge catheters. Arms ideally, maybe neck veins, external jugular, or groin, femoral. If IV access is tough, they can use an intraosseous line needle right into the bone marrow. It works surprisingly well short term.
Into the bone. Wow.
Yeah. And For massive resuscitation, the text mentions using warmed fluids and rapid infusion devices to give large amounts quickly and fight hypothermia.
Now, you mentioned some fluids to avoid.
Yes, really critical point. Albumin solutions and probably other colloids, those fluids with bigger molecules, generally avoid them in trauma.
Why is that?
There was a big study, the SAFE study. It actually showed higher mortality in trauma patients getting albumin compared to saline, especially those with traumatic brain injury.
Wow, okay. No albumin.
And glucose solutions, like D5W, generally not effective for resuscitation in the initial phase. Stick to saline-type fluids and blood products if needed.
Got it. What about pain? Must be agony.
Yeah, providing good pain relief analgesia is important, though sometimes overlooked initially. 4V opioids, usually carefully titrated.
Titrated means adjusted carefully.
Exactly.
Yeah.
Just the dose based on their pain and vital signs. And the text specifically says don't give shots in the muscle or under the skin.
Why not?
Because if they're in shock, blood flow to those tissues is poor, so absorption is totally unpredictable. You might give a dose and nothing happens, then later it all gets absorbed at once. 4E is the way. Sometimes they need quite large doses.
Okay, so initial assessment, immediate treatments. Then what? The text mentioned a secondary survey.
Right, the secondary survey. This happens once the immediate life threats from the primary survey, CABCDE, are managed, and the patient is hopefully starting to stabilize a bit.
And the point is...
Injuries get missed easily, especially if there's one really dramatic injury distracting everyone. So you need a systematic head-to-toe exam, front and back. Look and feel everywhere for cuts, bruises, scrapes, lacerations, contusions, abrasions.
Head to toe.
Sometimes, in complex cases, you might even do a tertiary survey later on, another detailed check.
Okay, so let's walk through that secondary survey head first.
Head. Detailed neuroexam, consciousness, pupils, any weakness. Check ears and nose for fluid leaks, CSF or blood. Could mean a skull fracture. Check the whole scalp carefully.
Face.
Look for bleeding that could affect the airway. Check facial bones, jaw movement, any tenderness suggesting fracture.
Spine. It seems super critical.
Absolutely. If consciousness is down, assume a C-spine neck fracture until proven otherwise by imaging. Look for signs of spinal cord injury, weirdly warm limbs below the injury, breathing just with the diaphragm, paralysis, priapism in men, loss of anal tone. Check the whole spine, thoracic, lumbar feel for tenderness, deformity.
Chest next.
Thorax, yeah. Single rib fractures aren't usually life-threatening on their own. But look for blood in the chest cavity, hemothorax, collapsed lung, pneumothorax, bruised lung, contusion, flail chest where a segment of ribs is broken and moves weirdly.
You mentioned tension pneumothorax earlier.
Yes, that's a killer. Air trapped in the chest, squashing the heart and lungs, needs spotting and treating fast. The text also briefly mentions rarer serious heart or major vessel injuries.
Abdomen. Lots of potential for hidden trouble there.
For sure. Spleen, liver, mesenteries, the tissues holding the organs often get damaged. Bleeding behind the abdominal cavity, retroperitoneal hemorrhage is common too.
What about things like pancreas or bowel?
Less frequent, but easily missed initially. Might only show up later with signs of peritonitis inflammation inside the abdomen from leakage. Kidney injury too, look for blood and urine, pain in the side.
Pelvis.
Pelvic fractures can be hard to spot clinically, especially if the patient's unconscious. But they can bleed massively, especially fractures at the back.
Is there anything they can do immediately?
Pelvic binders. A device wrapped tightly around can help stabilize it and reduce bleeding early on. Also need to check for bladder or urethra injuries, especially with front pelvic fractures.
And arms and legs, the extremities.
You can lose a lot of blood, a liter or more, just from a femur fracture. The thigh bone. Long bone fractures are worse if they're open through the skin, comminuted multiple pieces or displaced, or if nerves or arteries nearby are damaged.
Okay. And finally, just examining the whole external surface.
Yeah, looking everywhere for bruises, contusions, which can be serious, especially after falls, and easily missed if you don't check the back. Road crash victims might have burns or abrasions too, which can give clues.
So secondary survey is that thorough check to catch anything missed initially. Let's circle back to shock. The text goes into more detail beyond just recognizing it.
Yes, understanding the type and cause of shock is critical. Remember, cold, pale limbs mean shock until proven otherwise. And tachycardia isn't always there. Low BP is often light.
And hypovolemic is the most common.
By far in trauma.
Yeah.
Caused by losing blood volume.
Where can that blood loss come from? Some obvious, some hidden?
Exactly. Obvious external wounds, of course. Major fractures, femur, pelvis can bleed a lot internally. You might see swelling or see it on x-ray.
What about inside the body cavities?
Bleeding into the chest cavity, the pleural space. Chest x-ray picks that up. Chest tubes can monitor it. Leading into the abdomen, the peritoneal cavity, that's where diagnostics like FAST or CT come in. Clinical exam of the belly can be unreliable.
Okay.
And bleeding into the retroperitoneum behind the abdomen, harder to spot sometimes. Might see it on CT or suspect it with certain fractures.
So internal bleeding can be really tricky. What about other types of shock?
Right. Cardiogenic shock, the heart pump fails.
Mm-hmm.
In trauma, maybe look for swollen neck veins. Could be caused by tension, pneumothorax, squashing the heart. Maybe a coincidental heart attack, fluid around the heart, tamponade, or a direct bruise to the heart muscle, myocardial contusion.
Okay.
Neurogenic shock from spinal cord injury, usually high up, low blood pressure, but weirdly warm, flushed skin because nerve control of blood vessels is lost. Often see other signs like low anal tone, but it's a diagnosis of exclusion to rule out bleeding first,
Right.
and septic shock from infection. Possible later if they aspirated, but very unlikely to be the cause of shock right at the beginning.
So focus mainly on hypovolemic shock early on, but keep the others in mind. To find that internal bleeding, what are the main diagnostic tools used early?
Several key tools. Abdominal ultrasound, or fast-focused assessment with sonography for trauma. Increasingly common.
What's the benefit?
Non-invasive, quick. Uses ultrasound waves to look for free fluid, likely blood in the abdomen or around the heart. Pericardial effusion.
Sounds great. Any downsides?
Yeah, it has limitations. Very operator dependent, relies on the scanner's skill. Can miss bleeding, false negatives. Can sometimes see fluid that isn't blood, false positives. Not good for bowel rupture or pelvic bleeding specifically.
So when is it most useful?
Its main strength is in the shocked patient. If FAST is positive shows fluid, it often means straight to surgery, laparotomy. No more waiting for other scans.
What about DPL, diagnostic peritoneal lavage? You mentioned that.
Yeah, used less now. FAST is largely taken over. But it still has a role sometimes. Helps diagnose bleeding or bowel injury.
How does it work?
It's invasive. Small cut in the belly, catheter in, run some saline in, drain it out, and check the fluid for blood cells, maybe amylase for organ injury.
Sounds more involved. Drawbacks.
Being invasive is one. Can interfere with later exams, need caution in pregnancy, previous surgery, major pelvic injury. Positive results are based on how much blood or certain cell counts are in the returned fluid, but the exact numbers are debated.
So FFAS is generally preferred now, if available?
Generally, yes. Quicker, non-invasive.
What about CT scans?
CT of the abdomen and pelvis is increasingly the go-to for stable patients, if they're stable enough for the scan.
Why CT?
Much better availability now. Faster scanners. Gives incredibly detailed pictures of organs and bleeding. Needs 4V contrast, sometimes oral too, and expert radiologists to read them quickly.
Any limitations?
Sometimes miss injuries to the diaphragm, pancreas, or hollow organs like bowel. But seeing free fluid on CT without obvious organ injury makes you suspicious of a bowel problem.
So for stable patients, CT gives the best overall picture. Now, the text moves into some advanced stuff. Damage control resuscitation, massive transfusion. Sounds like this is for the absolute sickest patients.
You got it. Damage control resuscitation, DCR. It's a whole systematic approach for patients who are literally bleeding to death, exsanguinating. It's got several parts. Hemostatic resuscitation, permissive hypotension, and damage control surgery.
Okay, let's unpack that. Hemostatic resuscitation.
That means early, aggressive use of blood components together, red cells, plasma, platelets, sometimes whole blood. The idea is to get back something close to whole blood to fight the coagulopathy, the clotting problems that happen really early with massive bleeding.
Giving plasma and platelets early, not just red cells.
Exactly. Studies show using higher ratios of plasma and platelets to red cells improves survival. They also monitor things like fibrinogen and calcium. And they use special tests like TEG or ROTEM to see how the blood is clotting in real time and guide therapy.
And that links to massive transfusion protocols, MTPs.
Precisely. Coagulopathy is common in hemorrhagic shock, and just pouring in standard IV fluids makes it worse by diluting clotting factors. So hospitals have MTPs for patients expected to need huge amounts of blood.
What's the core principle?
Give more plasma and platelets relative to red cells during resuscitation. It definitely improves outcomes. Plus, we now have drugs like tranexamic acid to stop clots breaking down, and concentrates of clotting factors like prothrombin complex or fibrinogen.
Okay, now permissive hypotension. Sounds weird. Why allow low blood pressure?
Okay, specifically in penetrating trauma stabs, gunshots, there's a concern that pushing the blood pressure up too high too early before the bleeding is surgically stopped
Yeah.
might actually pop off clots or dilute clotting factors more, making bleeding worse.
Ah, okay.
So permissive hypotension is about limiting standard IV fluids initially. aiming for just enough pressure, maybe a systolic around 90, to keep vital organs perfused until surgery fixes the leak. It has shown some early survival benefits in penetrating torso trauma during the operation itself.
But not for everyone.
Absolutely crucial point. Generally not for blunt trauma patients with a head injury. Low blood pressure is terrible for an injured brain. There, you need to avoid under-resuscitation and keep the brain perfused. It's a very specific strategy.
Very important distinction. Okay, lastly, damage control surgery.
This is for the most critically ill, physiologically unstable patients. It's abbreviated surgery.
I mean,
Quick operation. Just to stop major bleeding and control contamination, like from a bowel injury. Don't try to fix everything definitively. Then, get the patient to the ICU.
why move them then?
To resuscitate them further, warm them up, correct the acidosis and coagulopathy, that lethal triad. Once they're more stable, maybe hours or a day later, they go back to the OR for the definitive repairs.
A staged approach.
Exactly. Military experience even extended this to using minimal fluids before that initial hemostatic surgery. But again, the text cautions. Don't apply this broadly to less severe blunt trauma, especially with head injury, or if you're far from a major trauma center.
So damage control is about immediate survival first, stabilize, then definitive fix later, for the absolute worst cases.
Precisely. Trying to do a massive, long operation on someone who's that unstable can just push them over the edge.
Wow. Well, this has been an incredibly thorough deep dive. We've gone from the absolute first moments of triage right through to these really complex resuscitation strategies.
We really have. Covered the CKBCDE assessment, recognizing shock and breathing problems early, the basics of fluids and blood, the secondary survey check, and these advanced ideas like DCR and MTP for massive bleeding.
And it just hammers home how vital a coordinated team approach is. So many things happening so fast.
Oh, absolutely. Teamwork, clear communication, sticking to those systematic approaches, that's what makes the difference for these patients.
So when you think about all this, the rapid checks, the life-saving actions, the evolving science behind resuscitation and surgery, it's incredibly complex. It really makes you wonder, doesn't it, about the ethical pressures, making those split-second decisions, allocating resources under extreme stress. What are the hidden ethical challenges in this? It's definitely something to ponder.